Hi, everyone, and welcome back to another episode of Public Health Career Conversations. I'm very pleased to have with me today a colleague and friend, Ms. Vimla Moodley, who is an independent public health consultant with many, many years in public health. I'm not going to go too much into the details of Vimla's bio because we are going to get into those details as we converse. So Vamla, thank you so much for joining us today. I'm really happy to have you here. Getting into your journey, I think, we had a bit of a pre-discussion and, it seems like there wasn't really a specific point at which you were stopped and thought, I need to go into public health. It's more sort of an evolution for you based on your undergraduate and your career as it progressed. So let's start from the beginning. Maybe walk me through what you had initially studied in university, and then how that evolved over the years until the point that you are at now.
Okay, thank you very much for the opportunity. When I started, I must admit, I had no idea that I'd end in health. As a young girl, I think my parental journey or my parental pressure was more in line with, oh, my daughter would like her to be a doctor kind of thing, which I think every parent has that ideal. And when I got to university and having finished matric, I obviously had done all the courses that would have geared me to have gone the route that my parent wanted in terms of, doing the sciences, the S7 as it was called then, etc. Got to university and found that, that was not what I wanted. Personally, that was not my desire. I thought of law, enrolled for the first semester and decided law wasn't something that I was inclined to do. And then went to the arts because I really liked English. And, I had this feel for literacy and literature and all of that. So I did a Bachelor of Arts degree and did sociology as a major and English, which is not a combination that's, going in any direction. And completed that degree, but along the way, added on communication and philosophy and a kind of mixed match of subjects, but my majors were English and sociology. Finished that degree and then thought, now what? What do I do with this? And because I liked languages, I also did Afrikaans Nederlands, which is, as a second major. And the sort of clear progression from there in terms of languages was teaching. So I did a university higher diploma in teaching and completed that and taught for 3 months. And because I was a Durban girl and I couldn't get placement in Durban, I had a school in Maritzburg. And then I was commuting daily for 3 months and realized that that was not the best. Whilst I enjoyed having to be in a classroom situation and teaching, etc., it was not really what I wanted to do. And I then left the teaching profession, was home for a few months, trying to find a job, and met a friend who said to me, why don't you apply to the Department of Health? They have a position for a community liaison officer. I had no idea what that meant. And I thought, well, I'll give that a try. Whilst I was at school, I was in a youth group and we did reproductive health. We did a sexuality education course. And I thought, well, that's interesting. Maybe that's something in line with what I could do. But having had education as a post-degree kind of major, as it were, because I carried it over. I did education 3 whilst I did my diploma in teaching. I thought, well, that's a good combination. Maybe it's health education. So when I joined or went for the interview, I was told this is all about reproductive health. We need to do a family planning. We have a family planning program. We're trying to reach out to communities. And given that you've got sociology as your major and your degree, how do you feel about having to be heading an educational program in health? And I thought, wow, that's interesting. That's really what I think, I have a feel for. And the whole idea of community engagement, community action, being involved with different sectors really attracted my attention. And I felt, this is something that I think I could really apply my sociology, had the education background, and then explore the whole health content and use that as a mix match in terms of what I did. And needless to say, I was thrown in at the deep end into this. They called it then the family planning program in the 80s. It was a very robust program. They had health workers whom they called health advisors in KZN, and they had community health workers, but the health advisors that were part of the reproductive health program were more honed into or concentrated on maternal and child health and contraceptive health. So that was my beginnings in the Department of Health as a community liaison officer, managed these health advisors, provided training for them, mentored them, orientated new people into the program. And then my journey progressed to adolescent and sexuality education, into schools, working with the Department of Education, then moved along the ranks to become Chief Community Liaison Officer, being involved in strategic planning, management, action plans, looking at health priorities, identifying completing community profiles based on, the disease burden, et cetera, and moved along the ranks to assistant director and eventually to deputy director, which in the provinces is regarded as a program manager. And that evolved to my position as program manager for health promotion. Given that my background and what I was doing in communities and within, a socio-ecological model for social and behavioral change communication, it was looking at individual education and then interpersonal education and then obviously community education and then societal. From a social determinants of health perspective. And that was really interesting because that involved all health issues. It wasn't just sexual and reproductive health. It was TB, it was HIV, it was all of those. And at some point during my career, when I was still in KZN, I was the coordinator for HIV and AIDS, because in the 80s, HIV/AIDS was just emerging at that point. And, it was a new program. There was lots of myths and stigma, and people really didn't, the department was still finding its feet as to how best to address the issue, given all the complexities in the 80s around HIV and AIDS. So that was for me, I kind of pioneered that program in KZN, being the regional coordinator for that. But sprinkled in between all of that, we had cholera outbreaks, we had issues around displacement, and there was some riots in the Mahatma Gandhi, Phoenix area at the time, and people were displaced. So it was, from a public health perspective, it was a mixed match of a whole range of issues to be addressed, but not from a clinical perspective, from a non-clinical perspective, and looking at public health through the eyes of the social determinants of health. It was later on that the commercial determinants of health became more apparent. I mean, that's more recent now. But I think at that point in time, I really cut my teeth on community development being key for health. And there was a program then called the Population Development Program, where the emphasis was on promoting and improving the quality of life in order to have a health benefit. And I think it goes back to Maslow's hierarchy of needs, where if you don't meet physiological needs and meet your basic needs, talking about health, it would make no difference. So the idea was, if you could improve the quality of water, sanitation, health hygiene from a community perspective and get people involved in their own health so that they could make decisions about their own health, that in a way would lend to a better quality of life and have a better health response, and it would promote health-seeking behavior. And for me, my foundation of public health comes from that perspective. I'm very grounded in that, and that began my journey. And in 2000, I then, in the year 2000, moved to the Provincial Department of Health, which is Pietermaritzburg based in KZN, as the program manager for health promotion. And at the same time, in that period, the position for the director for health promotion was advertised at the national office. So that was 2007. I applied for that position and was successful. So I moved to Pretoria as a director for health promotion. And in that time, my exposure expanded. I became more nationally focused. But because of my good grounding from local level, from community to district, sub-district, district, provincial, I'd walked through all of those levels. I had a very thorough, grounded understanding of public health. And at the same time, Wits University was offering short courses on public health. They had these short courses on, and I was then encouraging people in provinces to actually, my counterparts that were in the provinces that were health promotion managers, to actually attend the short courses. And I thought, well, why not attend it myself? And I did, because I thought, well, that'll be a great, learning position, as it were, to kind of hear what this is all about. Because up until then, I hadn't really considered doing a formal course in public health, as it were. I was doing short courses along the way. I did a diploma in project management. I did a diploma through UCT, the Oliver Tambo Fellowship on health management with UCT. I did other things in between, short courses and so on. Lots of exposure and training, obviously, in health, with the various health programs that were offered at the time, from within and outside of health, through WHO, etc., and other donor organizations. And then joined National Health with having more of involvement with international partners and donors, and all of the activities that obviously the national office is responsible for, and was responsible at that point for tobacco control. And I was then, because I was the director for health promotion, my responsibility was to be the technical lead for tobacco control. And at that time, in 2003, 2004, 5, the negotiations for the Framework Convention on Tobacco Control was being negotiated. So when I got to national office, there were discussions then on a protocol to eliminate the illicit trade on tobacco control. And I was very involved in that, in WHO work groups and so on. And whilst I attended the short courses at Wits on public health, I thought, well, maybe I should do a master's in public health. And that's what I did, and that's how we met, during that time. And it was really interesting because it was just formalizing all of my experiences, all of my skills that I've had throughout the years in the MPH. And I enjoyed it so much because it was just bringing that all together and just saying to me, this is now part of a formal program, but it's based on all of that. And that to me was just the most incredible journey. I love that, still apply all of that in the work that I do up until now. And in 2018, I left the national office and then decided to work independently. And I haven't looked back. I've had very interesting pieces of work. I've worked with the UK funded program on NCDs. I was a technical lead on the Better Health program. I've been involved in tobacco control. I've done 4 reports, annual or biannual reports on South Africa on tobacco industry interference. And that's been also very interesting. I've done other work, other bits and pieces of work. Yeah. Thank you.
Thanks, Vimla. That is fascinating. And I'm really glad that we are speaking to you, because there's a lot, as you say, there are a lot of younger colleagues who have studied, whether it's health adjacent or even in your case, completely out of the health sector, and have this interest, or maybe don't even know that they have this interest in public health, but are trying to sort of figure out the next step. So it's really great to hear how that evolved for you? Because career paths, I think, are not sort of linear, and that's partly the impetus for this series, is that there's very few careers, where you know sort of the next step. I mean, medicine is somewhat one of them. You go and you study, and then you're a doctor. But even within medicine, there's like, oh, what do I specialize in next, or do I be a GP or a specialist? And so it is really nice to hear how your journey evolved from not being anywhere within health, but then how you managed to take what you did study and utilize it within the health field. So thank you for that. And it's also really great to just hear how you managed to, learn different aspects of public health. As you said, you got to sort of the master's later. And I think a lot of people sometimes think you have to study immediately in order to be in a field, whereas you can do short courses. You bolster your skills, and there's plenty out there. Like you said, you didn't really do immediately. You did project management, and you did the fellowship, which and then sort of later started doing more theory around public health. And so that's also really great reflection for younger people, that you don't necessarily have to get into a master's program immediately. You can try and get skills and knowledge elsewhere. But what I really wanted to just ask you to reflect on quickly is around what you studied in your master's program, because at the Wits, and as Vimla said, we studied together. You did the social and behavioral change communication stream, if I'm correct.
Yes.
I did the health management and policy stream. So there are streams within public health. So maybe it would be just useful for whoever's watching, to maybe just unpack what actually is social and behavioral change communication, and maybe a little bit about what you enjoy about it. Because if there's somebody, like you, who is, in the communications field, etc., and who's looking at this, they may not be aware that this is, a potential avenue. So maybe if you could just unpack that a little bit for us.
Okay, thank you so much for that, Atya. I think for me, the biggest challenge in social and behavioral change communication is the misunderstandings or misconceptions around health education versus social and behavioral change communication. And I think a lot of time and effort is spent, particularly by the public sector or by government, on resources that are not impactful and don't have the desired outcome. And I think a very good way of describing that is what Sarah in MPH at Wits very, very eloquently described it as the spray and pray approach, where you spray a community with posters and pamphlets, and then you just literally pray that they would have taken those pamphlets, read them, and understood and behaved appropriately. And I think that just sums up the misconception with social and behavioral change communication. I'd like to say at the outset that behavioral change is a process. It doesn't happen overnight. There are many stages, there are many components. It's a very complex discipline, in that you need to be able to understand whatever it is you're designing in terms of a program, communication, education, etc., based on needs, based on understanding, on perceptions, on beliefs, on culture, on norms, on standards, on socioeconomic circumstances, on basically a whole range of factors are involved in planning communication initiatives. And this is where I think we go wrong, because we are always we're not being proactive, we are reactive. And when we have outbreaks, or we have, a disaster, we're so ready to want to do things that we forget that we're talking about people, and people are complex, and that we need to be more cognizant and more sensitive to the needs of the people, and we need to be interactive in whatever we do, and we tend to be non-interactive. We tend to be reactive, and we go out and we just plaster places or plaster communities with posters and pamphlets and media messages, and the resources are very expensive, but it's never considered as to what impact, what do we want to achieve, what are the objectives. And I think, like anything we plan in public health, we need to be very clear as to how we do it and with whom. And it needs to be an interactive, well-grounded, evidence-based initiative rather than something that's very, quick and easy, and we think we want to achieve something readily, and it doesn't always work like that. Thanks. I hope I've answered your question.
You have, and that's a really great point because, as you say, many people think that throwing information at people is the way to get them to do whatever you need them to do. And I always remember when I was working at the clinic and we started a new triage system, and this is not really social behavioral change communication, but we had put up, posters that said, if you are here for the dentist, please go here. And people would still sit in the long queue and then get to the, the triage and then be told, but, there's a poster. But you realize that people, for whatever reason, if you're sitting in a facility, you're there, you're not well, you've got a toothache or a cold, you're not really caring about the empty that's sitting in front of you, And so I think it's a really great point around sort of meeting people where they are, but also taking into account the nuances around people. Everyone different interests, or back to your point around Maslow's hierarchy, right? You're not going to be consuming health information that has really little relevance to you if you're starving. So again, it's a very important point around how we engage with people. And I think the misconception, as you say, is that health education is just sort of throwing things at people and just hoping that they will do something with that. And that's the one side of the coin. And then the other side of the coin is and I'm sure you've got plenty to talk about this, we won't go down it, but around miscommunication. And like COVID was a prime example of that. So it's not only just educating, but it's also combating.
Yeah, absolutely.
Education. Yeah. So I think we've sort of covered, I think you answered most of my questions around, why you studied your master's, etc. What is really impressive for me is how you've managed to kind of from your background in, as you say, in communications, but not really thinking about health, but really moved your way up the ranks into, different spaces within the health department. And I think that is quite a good example of how many people have to kind of navigate their careers. As you slowly move your way, you get more skilled, and you it doesn't just happen. You don't just get a degree and then suddenly find yourself in the National Department of Health. Like it takes many years and knowledge and skills. So my question really is around, if you had to look back on either someone who was in your position, when you just finished studying, or somebody who's contemplating next steps or considering public health as a career, what type of advice would you give someone who, may be thinking, what next for me? How do I navigate my career?
I think it's important to have a sense of what's out there and to do some kind of, I wouldn't call it research, but I think to have an understanding. If you've completed your undergrad degree, I think you need to be a little bit more flexible in your thinking and to think outside of the discipline that you've probably chosen, and look at the links. And I think often forget about the links. I mean, health, as I say, is an all-encompassing discipline, if you want to call it, or an area, an issue. Health is a really multifaceted. There's just so many aspects of health. You don't really consider it if you're thinking narrowly about it. You're in that biomedical model. And I think it's so important to extend that thinking beyond your biomedical model of thinking. I think the links, and it's becoming more and more apparent now, information and how important AI is, and information and technology. And you often don't think that. You think, well, this is a clinical biomedical model. Why do I need to be involved in information and technology and all of that. Now, technology and AI, not only in a clinical perspective, in a non-clinical perspective, is just as important. But if you're not looking at it through that perspective, it's very hard to see that kind of link. And I think that extends beyond just clinical and behavioral change to infrastructure and things around planning and strategic planning and resources and procurement. And there's just so many aspects to health, rather than closeting it or closing it off and saying, this is just a clinical, it's a patient, doctor-patient, nurse-patient interaction, if you know what I mean. It's much broader. And I think if you can open yourself to all of those areas, sit down and look at health, but in its broadest perspective, and then see how best, whatever you've done or where your interest lies, how would that fit in? Mm-hmm. Maybe that's one way of looking at it.
That's a really great reflection. I think, the way you've unpacked it, let me just say for those who are watching, there is, Vimla hasn't specifically said this, but there is a framework within public health, the WHO building blocks around health. And the building blocks are human resources, information and technology, medicines and products. And I'm trying to remember all of them, but basically, yeah. and even supply chain, as you talk about.
And so finance.
And financing, so you could study an HR degree, for example, and then, move into human resources for health, whether that is working in human resources in an HR department in an organization, or helping at a policy level with planning and understanding what planning needs are. So there's many ways, as you say, to juxtapose what you've learned in your undergrad and overlay that with health, with a health lens.
Absolutely.
And I think your journey shows that, like, again, not coming from a health background, but how utilizing those skills first at a community, and then sort of building on that, going all the way up, to different spaces. And I really think that this will, help anyone who's watching this who may not necessarily be from a health background, sort of understand that there is, like I said, there's many ways to get into public health. There's many paths to it, and there's also many paths within it. And so you really can connect those. So I think that piece of advice is really valuable to people, to just kind of unpack. And I'm hoping, like I said, that the set of interviews also sparks that idea. Like you say, not formal research, but hearing people's stories, they'll be like, oh, you're someone who came from a communications background, and how you managed to rationalize and navigate that in your career. So thank you. I've covered what I wanted to cover, all my questions. I don't know if there's any sort of last parting words that you want to add before we end.
I just would like to say to whoever's watching and to young people, not to give up hope. There's always something out there. It's just a matter of just talking to other people and just finding people that may have traveled the journey or are within health to get some advice, because you're not alone. You can get more information that would make you think around something that you definitely would find something interesting to do, and not to give up hope, because I think people are so frustrated right now with not finding jobs. And all I'm saying is there are opportunities. It's just a matter of finding those. Yeah. Thank you.
Yeah. That's really, and just to add to that, I think, I said this in my interview, is that when you hear all of us speaking who are, 15, 20, 30 years down the line, it looks like it was a cohesive journey, but it's easy to connect the dots when you look back. There were plenty of times, like ups and downs, when you may have also had that, where you're working in something and you're like, does this necessarily connect? This is not with what I started out doing. And so now it looks like it was linear, but it's not always. Lots of ups. So I think that's a really great parting reflection. Thank you, Vimla.
Thank you, Atiya.
All right, so thank you so much. And I wish you all the best for your continued work. It seems like you've got a lot of varied and very interesting projects on your plate. So really excited to see what comes of it next.
Thank you. Thanks very much.